Hello, this is Dr. Michael Shearer with Learn Lodi, a free resource for learning how to market, treatment plan, place, and maintain locator over denture implants. This video is aiming to describe the guided surgery solution for the Zest LODI implants. And what we're doing today is we're going to be utilizing a Anatomage surgical guide to place 4 2.9mm by 12mm long Zest LODI implants. I've assembled everything here that we need to place these implants with guided surgery. We need a surgical kit, and in this case we have assembled a premium surgical kit. We have our simulated patient, our Anatomage surgical guide with 4 implants and master sleeves, and we also have a 1.5mm and a 3.7mm insert kit. We traditionally like to package 4 of the 1.5mm with 4 of the 3.7mm inserts, and I'm going to describe these in more depth in just a moment. As you see here, we have the premium surgical kit. Included in the premium surgical kit is everything that you would need to place a Zest LODI implant, including all 4 osteotomy drills, drill extender, tissue punch, directional indicators, the core tool, torque indicating wrench, drill stops, and driver tips. So guided surgery with a Zest LODI implant is going to utilize similar drilling protocols as what has been described in the traditional non-guided surgery indications for the Zest LODI implant. And that's all described in the locator over denture technique manual on page 8, as you see here. And what we're going to be doing is describing a D2 and D3 bone type drilling protocol for this dummy mandible sawbones replica. So the traditional non-guided surgery protocol is to utilize 3 drill diameters for a 2.9mm by 12mm implant. That includes the initial 1.2mm pilot drill, a 1.6mm second drill, and a 2.1mm third drill. And what we're doing is we're sequentially enlarging the osteotomy for preparation for the implant. The initial 1.2mm pilot drill is drilled to full depth. The 1.6mm is also drilled to full depth, and the 2.1mm is drilled 4mm short. And what that does is it allows for a stepped osteotomy creation, so that way the self-tapping nature of this implant can grab apically as well as coronally upon insertion. The only difference between this and the guided surgery protocol is we're going to be adding one additional step at the beginning, and we'll describe that in just a moment. So again, we've assembled everything here that we would need for guided surgery for the Zest LODI implant. The first step of any guided surgery solution is to ensure intimate and complete adaptation of the guide to the soft tissues, as you see here. And what we're looking for is we're looking for blanching of the soft tissues coronally, and facially and lingually. So I'm going to be pushing on the guide in the mouth, ensuring that I've got blanching here, 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 occasionally in here, and in here. Now, what Anatomage will do is they will provide relief in the areas of the master sleeves, so that way there's not pressure or excessive amount of guide contact in that area. So guide contact in full adaptation is important in these areas in the posterior, but around the master sleeve you don't want that master sleeve tube touching. What Anatomage will also do is they will put a certain amount of distance and space between the top of this master sleeve and insert to where the implant position is going to be. And in this case, what we've done is we've calculated the distance from the tip of this drill to where this physical drill stop occurs. And that happens to be 19mm. So what Anatomage is doing is they're calculating the distance from where the drill stop is going to be occurring once that contact occurs and the depth of the implant. So by doing that, they can reverse engineer and figure out a way to have a complete guided surgery solution. It sounds confusing at first, but once I go through the steps, it'll be a lot clearer. So as you see here, I'm looking down at a master sleeve inserts for the Anatomage guide. These are 5.1mm wide, and they receive the inserts to step down the drill sizes, as many other implant surgical solutions do. Guidance occurs by 2 different methods with the Zest LODI kit. Importantly, what I like about the guided surgery solution for the Zest LODI kit is that you don't need a special drilling system or a special surgical kit to have guided surgery. You can use the stock, basic, or premium surgical kit to allow for guided surgery. And what we've done is we figured out the diameter of the drill and matched up correspondingly to inserts that are provided by Anatomage. And this is a 1.2 millimeter drill with a 1.5 millimeter insert. There is going to be a little bit of wobble room that exists around where this master sleeve is. Now, you don't want it to be too tight, or else when you start drilling inside the mouth, the tolerance is going to be restrictive enough where it's going to cause a lot of binding effects when that drill is inserted. So we want a little bit of wiggle room for when that implant and osteotomy placement occurs. The second method of surgical guidance is to utilize the drill stop that comes with the surgical kit, and the drill stop width is 3.5 millimeters wide. By utilizing a 3.7 millimeter Anatomage insert, we can then also have surgical guidance occurring during implant osteotomy preparation. And now what's going to be happening here is that this drill stop in contact with the insert is going to be controlling your trajectory. The depth is going to be controlled by the drill stop itself. So as this is inserted into the guide, it's going to be drilling down until it contacts bone right here. And that's where the drill stop controls the depth of the osteotomy placement. So the simplest and most effective way to have guided surgery for the Zest LODI implants is to follow a basic protocol. And the basic protocol involves utilizing the surgical guide with the inserts being snapped into place. And as I mentioned before, we have two different widths, 1.5 and 3.7 millimeters wide. And these are inserted into the guide just like so. And there's a friction fit that occurs between these four, as you see here. And here. Now, I do recommend not doing that while it's in the patient's mouth, and having your assistant inserting all four of these initial 1.5 millimeter inserts until fully adapted, as you see here. And then at this point, readapting that to the patient, so that way you have complete tissue adaptation. So now at this point, after anesthesia has been achieved, any sort of pre-medication or chlorhexidine rinses of your own choosing, you're ready to begin guided surgery for the Zest LODI implant. Now, as I mentioned before, you want complete tissue adaptation of the surgical guide. What is demonstrated purposes only, you can see here that I have a standard non-anchor pin surgical guide. You can also request anchor pins to be placed with your surgical guides, as you see here. And what the anchor pin will allow you to do is stabilize the surgical guide, just like so. And what that will occur is that when you have the anchor pins in place, the surgical guide is firmly adapted to the soft tissue, taking one more thing away from you having to think about it during the surgical procedure. As you see here, without the anchor pin, the surgical guide is loose. Now, clinicians can place 2 to 4 anchor pins, and in this case we use 3 for this surgical guide, and then also 3 for this maxillary surgical guide. Maxillary surgical guides are a little bit different as well, and you can go ahead and skip the anchor pins if you feel more comfortable with that. As you see here, this would be inserted into the mouth. I would be behind the patient and stabilizing the guide with my hands and pushing firmly on the palate while doing my osteotomy preparation. So this is an option for a clinician to consider. So now once the surgical guide has been stabilized, either with finger pressure or with anchor pins, you're ready to begin implant osteotomy preparation. The first initial step is to take the 1.2 millimeter pilot drill with a handpiece at 1200 RPMs. Now, many clinicians will also say somewhere between 1200 to 1500 RPMs is acceptable. Some may also consider going down to something like 800 RPMs. It is a clinical preference, and both of those are correct. So now at this point we have the 1.5 millimeter inserts in place. We're going to be utilizing the 1.2 millimeter pilot drill and running at 1200 to 1500 RPMs until we have a physical stop occurring between the top portion of this drill and the top portion of the insert that's already in place on the surgical guide. Now I'm going to run through a demonstration so that way you can visualize. I'm going to begin my drilling protocol and my drill outside of the mouth. Now you'll see here this is a demonstration, you won't see any water, but I do recommend sterile saline as an irrigant solution. I'm going to begin my osteotomy and my drill spinning at 1200 to 1500 RPMs outside of the surgical drill, outside of the guide, and drilling down until I have drilled down all the way, pumping up and down, and carrying over to complete all 4 osteotomies. Now as you see here, I've drilled through the 1.5 millimeter insert and I have the 1.2 millimeter drill. I'm going to remove the 1.2 millimeter drill and the guide. As you see here, I've got 4 holes that have been punched initially through the soft tissue. I'm going to utilize my air just to clean up some of that. And you can see here I've had 4 initial holes that have been marked on the soft tissues. It is a recommendation at this point to go ahead and utilize your tissue punch with the 1.2 millimeter initial pilot osteotomy. This guide pin is going to fit intimately into the 1.2 millimeter osteotomy and allow you to precisely excise the soft tissue. So what I'm going to do is I'm going to insert and just visualize how that goes down into place, just like you see here. Now I recommend 800 RPMs for the tissue punch procedure. And what I'm going to do is I'm going to hold this because this rubber mucosa tends to rip a little bit. There we go. Yay. There we go. That's a much cleaner osteotomy. As you see here, I'm going to zoom in a little bit so you can see. And now the tissue plug is going to be plugged out by the assistant. You get a pretty clean adaptation or pretty clean excision. And again, you can see here I have a little tissue tearing because this is the rubberized mucosa. I'm going to hold this the best I can. There we go. And the same thing here. And the same thing here. There we go. 4 clean osteotomy holes and 4 clean tissue punches. Now at this point, while I'm drilling my tissue punch, I can also have my assistant removing the 1.5 millimeter insert and placing the 3.7 millimeter insert. And how we do that is we have an insert tool that's going to come up from the intaglio surface of the guide, pushing with firm pressure until that little insert pops out. And I'm going to do that to all 4 of these. There we go. And now I'm going to do a quick visual of my implant proposed osteotomies. And what I'm looking for is to make sure that I've got a center hole going straight down the master sleeves, as you see here. That indicates to me that my initial guidance is correct. And at this point, if you have a significant derivation from where you think you should be, you can correct it. Once you go beyond the initial 1.2 millimeter drill, the amount of correction that you can do is minimal. So now at this point, the rest of the surgical guidance protocol is going to be occurring with the 3.7 millimeter sleeves, or the inserts. And I'm going to snap those into place as you see here. Here, and 3, and 4. And these inserts are all available individually in case you do have one that falls on the floor or you do lose one. I'm going to zoom out just a little bit. And again, readapting my surgical guide into place with my 3.7 millimeter inserts, I can see that my initial plan is following my desired protocol, my desired trajectory. Now at this point, we can take our 1.6 millimeter drill, adapting a 12 millimeter drill stop, and now I can prepare my second osteotomy through the 3.7 millimeter drill. There we go. What we want to do is we want to find that initial hole with the 1.6, and I'm going to drop that into place. What I don't want to do is just start drilling from the outside. I actually want to feel that hole, and I'm going to start drilling and is watching it drop into place, just like you see here and there. Now I'm going to pump it up and down, making sure that I have nice, there we go, nice amount of coolant effect that can occur all the way down into that osteotomy. I'm going to clean off my drill and continue on with the next 3 osteotomies. So as you see here, I've taken the 1.6 millimeter drill with the 12 millimeter drill stop and drilled down until I have physical contact of the drill stop with the bone, as you see here. Now the difference is that I'm going to be doing that with the insert in place and the guide in place, simulating this is a clinical patient. So now I'm going to take, again, my 1.6 millimeter diameter drill with the 12 millimeter drill stop, holding it in place and finding my initial 1.2 millimeter osteotomy, keeping my osteotomy drill as parallel as possible and allowing the insert to cause guidance once it gets down into here. There we go. And again, cleaning off my drill, finding my initial hole, and pumping up and down. As we look through the 3.7 millimeter insert, we can see that we've taken the 1.6 millimeter diameter drill to full depth osteotomy, and in this case, 12 millimeters. What we're going to do at this point is remove the 12 millimeter drill stop from the 1.6 millimeter drill, replace the 1.6 into the holder, and I'm going to receive the 8 millimeter drill stop with the 2.1 millimeter diameter drill, snapping into place, as you see here, and inserting it to my handpiece. So the third drill, which is the last drill for a 2.9 by 12 millimeter implant, is going to be performed with the 2.1 millimeter drill with an 8 millimeter drill stop. What we're going to do is we're going to evaluate where our initial osteotomy holes are. Again, very similar to the 1.6 millimeter drill, I'm going to find that initial osteotomy here and here, and I'm going to start drilling once my burr is just lightly engaging into that osteotomy, carrying on onto all 4 osteotomy sites. Just like so. And again, we're going to stop 4 millimeters short to engage apical as well as coronal bone upon implant insertion. 800 RPMs with the 2.1 millimeter drill, diameter drill. Drilling until full osteotomy depth has been reached, pumping up and down with each individual drill. Again, stopping before each site. I like to find that initial contact, drilling down until I drop down into place. So now looking at my implant osteotomies, I'm going to do one last double check, which is to ensure that I have nice parallelism and centering of the osteotomies in the proposed surgical guidance situation. I'm going to remove my 2.1 millimeter drill with the 8 millimeter drill stop. And at this point, all of the osteotomy preparation has been completed. There are two options available to the clinician. First and foremost, you can insert the implant through the 3.7 millimeter guide insert. If you feel more comfortable, you can always remove the surgical guide and place the implant without the guide in place. So for demonstration purposes, I'm going to insert the two implants on the patient's left using the surgical guide. And on the right-hand side, I'm going to insert the implants without the surgical guide. So readapting the surgical guide in place, looking down the osteotomies, I know that I'm going to have pretty good guidance as well as pretty good parallelism. I'm going to take my handpiece with the isolatch driver. I'm going to snap that into place and get ready for the implant pickup. Now what Zest does is that they do include in the locator overdenture complete packaging, includes everything that you see on here, including the implants. So in this case, we're using a 2.9 by 12 millimeter implant with a 2.5 millimeter cuff height. If we remove the packaging and open up the box, we see here on the inside that it comes packaged with the implant plus the locator abutment in this sterile tube, as well as everything that you would need to attach it to a complete denture to convert it into an overdenture prosthesis. The blue attachment, the pink, the O-ring spacer, the extended range red, and the black processing cap. Also included for people that and clinicians that have paper charts is a sticker system to keep a record of the lot and the reference number of the implant. Now this happens to be a sample lot for demonstration purposes for this video, but in your own system it'll include a lot number. Once the implant has been removed, you're going to take this and then drop it onto a sterile field, or have your assistant drop it onto your sterile field. As I mentioned before, it's a complete package situation. So inside of the top cap is the actual locator attachment, and if you were to unscrew this portion, it just basically snaps off. Here's where the 2.9 by 12 millimeter implant is being housed. Insertion protocol involves taking a tapping setting at 50 RPMs. You're going to be inserting the implant into place, and it's going to snap on top of there with almost like a little click. As you remove the implant, you're going to notice that it's firmly adapted to the handpiece. If I hold it upside down, it's not going to drop. Now over time, this little O-ring that's inside of here does need to be replaced, so do be careful. Every time that you do go through with these implant surgeries, at the end of the procedure, verify that all the O-rings in the entire kit are still in good working order. The implant driver will still work, but you'll lose the ability for that implant to lock into place, so that's very important to understand. Now, the surgical guidance is going to be occurring, as I mentioned before, between the walls of this drill with the walls of the 3.7 millimeter insert. And in this case, what you're going to notice is that as the implant is inserted, the guidance occurs right at this point. So the width of this insert, this iso latch insert, is going to be allowing for surgical guidance to be occurring. And if I'm going to insert by hand, I can just basically take this and start inserting from here as well. But as I mentioned before, the two implants on the left-hand side of the screen, I'm going to be inserting with the surgical guide in place. So as you see here, we're ready to insert the implants. I'm going to zoom in just a little bit for everybody to see. There we go. Now at this point, again, I've already attached this to the isolatch driver. I'm going to be carrying it to the mouth very carefully with no water on a tapping setting. Be very carefully inserting into the sleeve until I feel that implant just barely grab into that implant osteotomy site. I'm going to keep my parallelism roughly parallel to the surgical guide, and I'm going to start my tapping setting nice and slow. Again, at 50 RPMs, I'm going to be stabilizing the guide and keeping my hands as straight and as parallel as possible until I feel that intimately grab just about right there. As you see here, if I remove this, the implant will be halfway inserted. If I remove the surgical guide, it'll give you an idea of where the implant is as well. What I generally tend to recommend is that the implant insertion occurs with the guided surgery solution until this top portion is flush with the insert, as you see here. Okay, and I've reached a torque value right there. So I'm popping out, and we're going to have to insert the rest by manual insertion. There you go. Grab the second implant I'm going to be inserting via the surgical guided protocol. Here. Taking this to the mouth, being very, very careful, keeping the soft tissue in the tongue away, finding my osteotomy, and inserting nice and slow until I feel that guidance occurring between the walls. I'm going to tilt a little bit so you can see a slightly different variation. There we go. And I've reached my torque limit just on this handpiece right there. And I can remove. So now what I like to do is I like to take the torque ratchet and just start taking that down until that is fully flush. I'm going to remove it so you can see how that implant is being inserted. Now, clinically, if you saw this torqued out beyond 20 to 30 Newton centimeters and the threads were this high up, I would recommend backing out the implant completely and then going in with an additional osteotomy, either deeper or wider, because this is too high up for a torque value to be reached. But since on my drilling unit I've really kept the torque value down low for demonstration purposes, so that way you can see me inserting by the wrench, I'm going to go ahead and carry on and continue forward. As you see here, I can either insert this by hand without the guide, or I can continue using the surgical guide for surgical guidance. And same thing on this other side. And I generally like to stop as soon as that little bevel right here on the top appears. And as you can see here, I've got plenty of room to go. But overall, I'm starting to look pretty good. Now for these other two sites, I am going to be inserting just by hand without the surgical guide. Again, same delivery. I'm going to click that into place, carefully remove, and slowly inserting just by hand, keeping as parallel as possible. Again, with the self-tapping nature of these implants, you can see here that I can cause a slight deviation of that implant as it goes into place. So it's important and critical that you do maintain a parallelism here. And the last implant. Last osteotomy here. If the clinician feels more comfortable, or if you feel more comfortable, you can insert the implant just by using standard hand instruments. So instead of delivering with the handpiece unit, you can deliver with this unit and carry the implant into place. As you see here, I'm going to start torquing down. I combine this by taking the torque indicating wrench here, snapping on my ratchet insert, and then taking either the short or long driver. Snapping into place, there's an O-ring that'll hold it there, and I'm going to carefully insert until the implant is flush with the bone. I like to keep my left finger, or if you're left-handed, the right finger, index finger, on top of this driver to keep it as stable and as parallel as possible. I occasionally stop just to verify that the implant is flush with the bone. I'm going to carry forward and do the rest of the 4, or the rest of the 3. Until I start to feel resistance. Now, since I'm working on a sawbones mandible, I'm not going to get a high amount of torque value here. But as you see here, what I like to do is I like to insert the implant and pull with just this lever arm. Now, if I'm going to start to get clinically this much torque value with 3 or 4 threads exposed, I am going to back out this implant by doing this procedure. I'm going to take the ratchet insert, I'm going to remove it from the inside, turn it over until the outside faces up, and I'm going to remove the implant halfway. Okay, turn it over and reinsert the implant. Now at this point, that self-tapping nature will allow you to get more apical grab, and it will allow it to go down into place with not as much torque. There we go, it's going in a lot easier this time. There we go. Looking good. And occasionally that part will come apart. And continuing torquing the other side. Stopping periodically. I still need to take that down maybe another millimeter or so, as you can see here. If I zoom in a little bit closer, there we go. Very nice. So as I snap the guide back onto place, you can start to see how a guided surgery solution can be very effective for the placement of Zest LODI implants. I'm going to use my insertion tool just to remove the 3.7 millimeter inserts. Just by pushing, again, just like the 1.5 millimeter insert. And this will allow you to visualize the precision of the guided surgery. Here we go. So the final checkoff stage is once the implants have been fully inserted, you're going to realize that you're going to have a torque value. And the torque value for immediately loading an implant should be somewhere above 30 Newton centimeters. So what we're going to do is we're going to take the inside of this torque indicating wrench, as you see here, with either the long or the short driver for the actual implant, and we're going to be measuring the torque value. And how you measure the torque value with this low torque indicating wrench is by holding one side and holding your finger out on the spring portion until you start to pull and the implant doesn't move on you. And once it moves a little bit, that's at your torque value. So right here I have 30 Newton centimeters of torque. As I move to the next implant, I also want to measure my torque value. 30 Newton centimeters. Here, 30 Newton centimeters. And here, 30 Newton centimeters. What I like to do at this point is look at the soft tissue and verify that my implants are in a correct position for the soft tissue to be effective. And what I'm going to do is I'm going to tilt that just a little bit and allow you to zoom in just a little bit more. There we go. And carefully just reflecting that flap tissue back just a little bit with a hand instrument. I want to verify that this platform is at or slightly coronal to where the bony surface is. That's looking good. Right. Now this mucosa that comes with this simulated mandible is only about a ½ millimeter thick. So normally what you'd like to see is that if you have a soft tissue depth of somewhere right around 2 to 3 millimeters, this top portion of this implant is going to be flush with the soft tissue. So the distance from this platform to the top of this implant screw, this threaded portion, is 2.5 millimeters. When the locator attachment goes into place, you want those to be roughly about the same. So the smallest locator cuff height that comes with the LODI system is 2.5. They also manufacture a 4.0 millimeter tall attachment. So what I recommend doing is having a stock of 2.5 millimeter cuff height implants for all of your implants. And then I also recommend keeping some additional 4 millimeter abutment heights. So as you'll see here, is in this particular vial, I'm going to open it up, and inside of here is where the locator attachment is. And this one is 2.5 millimeters tall. I also have a 4.0 millimeter abutment. As I mentioned before, I also keep a stock of the 4.0 millimeter tall abutments. as compared to the 2.5 millimeter abutments. And they are unique in their situations where the 4 millimeter tall abutment would be traditionally found more in the maxilla because of the soft tissue depth. So I'm going to zoom out a little bit so that way you can see the insertion protocol. Here. So as I mentioned before, this vial also includes the locator attachment in this top portion. As I remove this, I can easily let my locator tool and a locator attachment drop onto my countertop or onto my hands, and utilizing the core tool, I can insert this onto the implant. So at this point, I'm going to have my assistant unscrew this gold portion, and he or she can then snap this locator abutment into place, so that way it's being held by this white receiving cap. And what that allows you to do is have that locator snapping into place, so that way the risk of dropping it is significantly less. As I carry that to the mouth, I'm going to insert and start lightly screwing that into place until it just kind of breaks away. There we go. And now we have one of the 4 locators installed. I'm going to zoom in so you can see that just a little bit better. I'm going to grab the second locator, again in a similar fashion, removing it and snapping it into place. And lightly screwing down. So the first thing that you'll notice is that the locator that I've placed on this side versus this side are at 2 different heights. What I would tend to do here clinically is I would take this implant and want to drop it down just a little bit more. You do have to be careful with that though, that is, if you're at the bony crest right now, you're limited with how far you can drop it. But at this point, I'm going to insert all 4 of the attachments and make a panoramic radiograph to verify the implant position prior to doing anything of that nature. Removing the other locator attachment. And in this case, I have a 4 millimeter tall attachment just to visualize what that's like. I'm going to insert that into place. Again, just with a light finger pressure. And one additional 4 millimeter tall attachment. Now, obviously, this is not what you would want to do clinically, but I wanted to demonstrate what the 4 millimeter tall attachment would look like, so I'm going to remove that at this point. And notice you hear a snapping noise, and that's pretty ideal. And I'm going to be replacing with the 2.5 millimeter tall attachment. Now occasionally you'll run into problems where this won't snap easily into place. And if that's the case, what I recommend doing is lightly popping this off here. And here's where the locator tool triangle exists. What you can have an assistant do is lightly put that into place just so it's being held. But you'll notice that without that white cap, it's going to fall apart and it's going to drop. So the white cap is pretty important. But occasionally it can be difficult to snap it into place. So my assistants are trained to put that on first and then take the white cap and snap the white cap on top of the actual locator. And you can see here that it will snap into place very nicely, and it definitely won't come apart. So here now I'm ready to go ahead and insert. Finger pressure. And our last attachment. and popping that out. Putting it onto my tool first, snapping my white cap on top, and inserting. And here's what our clinical result would be looking like. And again, just to confirm, the guided result. Just about ideal. So clinically, the next step, once you've verified that you have hand tightened all 4 of the locator attachments like you have seen here, the implants have been fully checked in terms of their torque value. You know that you've reached at least 30 Newton centimeters. I would go ahead and verify that you are going to be in the correct position by the purposes of a radiograph, such as a Panorex. You can also use periapical radiography, but it can be more challenging, especially in a mandibular anterior region or in a maxillary edentulous site. If you don't reach more than 30 Newton centimeters as required for immediate loading, what I would do is I would stop at this point after the Panorex, hand tighten again, verify that your implant attachments are down all the way, and then put a soft liner in your denture. If you are above 30 Newton centimeters, you can immediately load, and what I would do at this point is torque your locator attachments down fully into place. So now at this point I can take my torque wrench with the implant driver in place, remove that, and get ready to torque using my locator insert. And that is also a square driver that'll snap into place, and it has the triangular portion of the locator tool as you see here. Now that I know and I've confirmed that my implant has been placed at higher than 30 Newton centimeters, I can torque my locator abutments up to that value. So if my implant only torques to 25 Newton centimeters, I don't really want to take it beyond 25 Newton centimeters as well. As long as you reach 30 Newton centimeters, you feel comfortable and confident with immediately loading, you can do that. To torque down the locator attachment, I'm going to take the locator insert with the locator wrench tool, and I'm going to zoom out so you can all see a lot better. I'm going to insert that triangular portion into the top of the locator tool, holding firmly with one finger in place, and I'm going to use this spring portion until I hit 30 Newton centimeters. As you see right there. There. Torquing down all 4 of the locator attachments. I can then go ahead and remove my locator insert, put my torque wrench away, and verify that the implants are in their correct position. Since I've already done that with a Panorex, I'm done at this point. This is the conclusion of this demonstration video, as this is only the surgical portion for the Zest LODI implants. In a further subsequent video, we'll describe the denture attachment selection and how to attach the denture to the locator. But at this point, we would then go ahead and create spaces in the denture and attach using our included peripheral components in the surgical box kit. So just as a review, I'm going to go ahead and visualize the surgical guide in place and confirm that this is our final result with guided surgery for the Zest LODI implant. And zooming in just a little bit so you can see. Surgical precision is achieved with the use of a surgical guide from a cone beam CT, Anatomage guide, or another surgical guide system. This is Dr. Michael Scheer from Learn LODI. Thank you very much, and tune in to the next video series that will include denture attachment as well as further patient demonstration videos. Thank you very much.